Hello and welcome to episode 16 of the Auditing Antics Podcast. So today we're going to be going over some of the recent questions that I've been receiving. And Michelle's actually not with us today. My daughter, her boyfriend, and my grandson were able to travel down to Florida to spend the week with my parents who live down there, and Michele is down there. So they're enjoying my grandson's first Disney day today. So they're all very excited about that. Now, what I did is I grabbed some common questions that I get both from people that are in my membership. And then also, I had put out a post, I think a couple weeks back on LinkedIn, just asking people to submit questions if they have any. So I've pulled some from a couple of different areas. And I did just want to highlight first that as a part of the membership, this is one of the main perks that a lot of people really appreciate with the coding compliance membership that I have through Stephanie Allard Consulting. And what that is you have an opportunity, and really it's unlimited, to submit your questions about compliance, coding, billing, and those come over directly to me, and they are reviewed and answered within 24 business hours. So some of what we're going to go over today has come through that particular part of the membership. Now, to start with, we have a question related to ED services. And this is actually something that over the years I've been asked a lot as well. So this person has a question about ED coding consults for psychiatry. And really, just so you know, this is going to be applicable to any specialty that has a consult in the ED. I hope you can help me. The patient came to the ED and the ED physician consulted psychiatry. Psychiatry sees the patient. They decided they do not need to be admitted. What was done in the past is that the psych doctor would bill an ED code like 99284 and utilize the place of service 23. However, after some research, they found that the psych doctor should be billing an office visit or office consult. Is that correct? So, like I was saying, with any specialty, if there is a consult in that ER setting, you have to remember that we are looking to payer guidance. So, AMA still has those consult codes available to us, and that's where they direct us, but we know the majority of the payers no longer reimburse those. So, when we look to the payer side, for me, I like to look at CMS as that base level. And then, you can look to your commercial payers as well. If they don't have any policies related to this, you want to default to CMS. So in the claims processing manual, there are two different places where CMS addresses this. The first one is in the main section where they talk about consultation services. And they specifically say in there, since as of January 2010, which has been quite a while at this point, because they decided to do away with reimbursing those consult codes, CMS directs us that we need to use the code set based on where the patient is receiving care. So that's the number one indication that the correct answer here is yes, this practitioner should be using an ER code. And I know, like I said, I've been asked this a lot. I don't know where it stems from that a lot of people have the misunderstanding that they'll utilize an office code. But when we think about it, when you think about that combination, let's put CPT aside and let's think of place of service. That place of service has to reflect where the patient is receiving care. So our place of service on that claim form is going to be place of service 23. And if your commercial payers, for example, do not direct you to utilize an office-based service with place of service 23, that can be problematic on its own just with the code combination. Now, CMS does have a second area. So inside of the claims processing manual, right underneath the section where they talk about consultations, they also have a section that talks specifically to emergency visit services. Within there, there is an additional subset that talks about using emergency department codes for physicians or your APP providers that are not specifically assigned to the emergency department, meaning that is not their main location that they treat patients. So, what CMS says is any physician seeing a patient registered in the ER may use ER department visit codes for services matching the code description, meaning they would, obviously have to be rendering that E&M service. It is not required that the physician be assigned to the emergency department. So one last component that really plays into this, and I get this question asked next, typically if I'm having it in a conversation, what happens because the ER is already billing out the ER code from 99282 to 99285. The answer to that is when these claims are going out, first of all, they're going out individually because both of our typically physicians or an APP practitioner, they need to bill that out under their own NPI number, right? And their own information related to their enrollment with the payer. So when those go out, remember the NPI numbers have information in the background linked to them. So if we think about taxonomy codes, for example, that will show the specialty or subspecialty of a practitioner, that's the type of information in the background that should very much so allow those claims to go out, even though they're both going with an ER code and the place of service 23, they should be reimbursed. There shouldn't be a problem. All right, now the second area is something that, I've had a lot of questions on this. I've started to talk about this quite a bit on LinkedIn and putting articles out and some other things like that, but there's still a lot of unknown around what we need to do when practices want to implement either weight loss programs, and I should say weight loss drug programs. And now I have another component that's coming up often with clients that are also wanting to know what they are to do when they want to offer what we would call lifestyle medicine. So, lifestyle medicine, for example, could be someone who has a focus in their practice on preventing progression of a disease or development of a disease. And they're looking at it from more of a holistic approach. So they may be looking to guide the patient with things like dietary counseling. Obviously that is going to go hand in hand with things like exercise and movement and hoping to guide weight loss in that way as well. And the thing that comes along with this is that we don't have base medical necessity. We don't have coverage for a lot of these services. So it's really important if this is something where you work inside of a facility or you're external to one like I am as a consultant, we need to make sure we're starting to have these conversations as the groups are wanting to implement these programs. Or if you find that they're already trying to take these, it sounds awful, but really alternate approaches. The other part of that too could be with supplements, guiding the patient with supplements. This is that territory we're getting into that is not necessarily going to automatically be covered. Now, before I talk about this and get into the questions about the weight loss piece that I want you in your mind to pair with lifestyle medicine, you want to keep in mind that this is going to be very payer specific. So I'm going to be speaking more from the perspective of CMS right now, but we have to remember that we have commercial payers out there who are already putting their stances out. And I'll talk a little bit about that after I shed some light on the questions here. But this topic is not something that I could ever directly answer in this platform, on a podcast. I can't answer this for all of you listening because it's going to be different. It's going to depend on your payer. It can even depend on the patient's coverage that they have specifically. So keep in mind, this is more of a guide as we broach this topic here, and it's something to get that awareness out there as to what needs to be done inside of facilities to make sure that you're on top of things. So the first question is, again, remember this is related to the weight loss program with medication. So how would you recommend carving out the non-covered service that is to be billed as self-pay? So the first part of the question is, would a flat fee be billed with an internal makeup code, or would an internal makeup code work? So what that's really referring to is, from the internal code perspective, there's times that you're able to set up like a dummy code. So it's more so to make sure that transactions are still moving through your practice management system. They need to be followed, they need to be tracked. I've worked with people in the past that have had systems where they don't even enter it in, like in dermatology or plastic surgery. And because it's self-pay and cosmetic, they don't even run it through the through the practice management system. That is very problematic. You still have to track all of this, even if you're going to be doing this through a self-pay program. So when we think to that question of, okay, how do we determine, for example, the fee? What do we do to make sure that we're following this internally? So my answer here is going to depend on the system that you have, meaning that some systems, some vendors you work with are able to set up what I was referring to as a dummy code, where maybe it could be like WGHTLS or something that shows weight loss. And then there would be a dollar amount because it would be self-pay attached to it. And then that would allow the regular charge entry process. It would not go out on a 1,500 claim form. It would drop automatically to patient responsibility as self-pay. So that's a really good way to track all of that information that still is required. Now, as far as the fee, that's something that has to be thought of collectively when you're looking at setting this up or fixing a program if it wasn't set up this way to begin with. So what I mean by that is, a lot of times, especially when we think about the drug weight loss side of what we're seeing right now, the practices that are doing this and really well, I would say, have one fee that is billed to a patient monthly, and then it's basically an all-inclusive fee, almost like a subscription fee, if that makes sense. So they determine, okay, we're going to charge 1,000 a month, but that's going to include all of the follow-up visits required. That's going to include the labs that we're able to run here on site on our machines and not send out. There's a lot of variables that go into what that fee is going to be. So you have to sit down, look at what you're going to be offering as a part of your weight loss program. From there, you would look to see what that fee is going to be that you're going to set for that. Now, I do get asked sometimes too, do you bill for the E&M service separately? That is a possibility as well, and that's something you have to think about with how you're structuring the program. If the patient is still going to obtain the medication, let's say through a pharmacy, and they're going to pay out of pocket for that, the pharmaceutical fee is not something the practice is going to have to worry about. So again, not one answer for everybody. You have to look at how that's going to be structured and what you're offering. Now, when it comes to the E&M portion, this is very important as well. So the next question is, does the self-pay portion have to be billed as an E&M service? So to give a little more context on this, and there's actually another part of a question that says, if a provider notes that they are treating the patient for depression with Wellbutrin, but they also have obesity listed in the assessment with treatment, well, I should reword this. So in the assessment, it's stating that the Wellbutrin is prescribed for depression. It's also going to be prescribed for weight loss because the patient has obesity. So thinking back to that question of, does there have to be a self-pay E&M service billed additionally and separate from other E&M? The answer is yes and absolutely. Now, when I say that, let's clarify it a little bit. So, what I mean by this is we have a situation that a patient has other chronic conditions that exist, let's say in internal medicine. They have other conditions that exist that are being treated, they are medically necessary. Everything would be covered as it usually would. What I'm personally seeing in my audits is that physicians and practitioners are trying to hide the weight loss component inside of the E&M with other chronics. Or when I go back from an audit and tell them, look, you have to do these other services because you cannot just bill an E&M and wrap it in there. Now, the reason for that is, remember, weight loss with drugs a lot of times does not have medical necessity or coverage. So yes, that claim could be paid if the payer is receiving the claim and has a level 4 E&M service on it. We see diabetes, hyperlipidemia, hypertension, heart conditions. That's going to pass the test, right? It's going to go through, it's going to be reimbursed. I strongly believe right now we are in a period of time where this is being done incorrectly the majority of the time. And in the future, we will start to see a lot of investigations happening from, the government level, the state level, the commercial payer level. They're going to want to get in on it as well if they don't cover these services. So you can't base what you're doing on the payment of the claim. And I know we say that all of the time, but this is even harder for people to understand because there's been so much focus only on whether or not the drug itself is going to be covered. So they'll look and say, okay, yes, we can get Ozempic, we can get Wegovy, the Part D for Medicare, or the prescription side of the plan for the other payers is going to cover it. So great. And what I find is that's the only insurance verification taking place. No one is applying it to the office-based services that, remember, medical necessity is that overarching criteria for the reimbursement of an E&M service. So if it's not medically necessary for pharmacy, it also is not for the office. And this is just, like I said, way too unknown at this point. People are not researching it. Most of the entities I work with don't even know that their physicians and practitioners are doing this. So it's something that when I talk with smaller groups about this, I basically say, yes, you may know that this particular practice, for example, needs to have a conversation about that, but this needs to be an organization-wide notification and discussion, because chances are that there's other people throughout, different practices or specialties that are doing this as well. So back to that component of the situation where we have depression with Wellbutrin. So the reason that I was asked this particular question, if you're not aware of this, is that Wellbutrin is actually one of the medications that has been, I'll call it, partially FDA approved for weight loss. The reason that I said partially, and maybe that's not the best way to describe it, is that Wellbutrin has to be combined essentially with another medication. And then in that situation, based on the FDA approval and label, it would be medically appropriate and approved for weight loss. So what I am seeing a lot of times is that they are giving only Wellbutrin. So by itself, that is not FDA approved. And again, that can be another misunderstanding. So if this feels overwhelming to you when I'm bringing up these specific things, the main takeaway here should be you have to look to FDA approval, then you have to look to the payer side. And, we recently had an update from CMS that as of right now, and, we'll go through other periods of times where we'll get updates on final rules and things like that. But as of right now, this administration is stating that they have zero intention of covering any weight loss drug medication starting in 2026, even if there is FDA approval for weight loss. So Again, I'm working with an organization right now with my good friend Terry Fletcher, and, we're having to tell them, okay, we're talking to you about this now. You're working to set up a program compliantly, which is great. But we also have to look to the near future because right now that's unknown as well. So that's even more reason as to why you have to be prepared with a self pay program which requires patient education. It's going to require a lot, and you may have to shift what you already have in place. But I can't stress enough how important this is going to be to your organization. Now, one last thing with that, when it comes to documentation, it is also a good idea to make sure that your providers are documenting two separate notes for the same reason that I'm talking about that your self pay program is going to show that you're separating these and you're not bundling them in essentially and trying to hide one service under another. So it would be very good practice to have two separate notes so there's no question about it, nothing's blurred, it's very clear, and then the program would show, that you're setting things up appropriately based on medical necessity. All right, the next question is, would a test be considered not, or would test considered as treatment but not ordered be considered a part of the treatment plan for that encounter, and would it increase the complexity of the visit? In addition to that, the question related to rapid tests, if you have one swab test that's done for COVID and flu combined, would it count as one test or two tests when we're looking at data and orders in that component of it? So, a couple of things here. One thing that we have to remember is when we answer these questions, we have to think about what the typical workflow is in the setting that's being referred to. So, when we're talking about rapid testing, this is something that's going to happen a lot in urgent care centers, absolutely pediatrics, family medicine, internal medicine. And we want to be careful because if I were to just respond, with what we know exists in AMA's guidelines that treatment that is truly considered and clinically appropriate at the time of the visit can still be counted towards the treatment plan. That could very, very easily be misconstrued as something where practices will think just because there's a typical protocol in place that they can automatically get credit for it if that's turned down by the patient or the parent or the guardian. So what I mean by that is, say we have a patient who comes in with fever and different other cold or flu-like symptoms. A lot of times when we're reading those charts, we see that the rapid tests are done when we're looking at strep, flu A, flu B, and COVID now happens a lot as well. So if I were to just answer this off the cuff and not give a full explanation, that could end up in a really bad situation where that practice I'm talking to believes in their mind that most of their visits support moderate complexity in a level 4, and that's not the case. Now, another component of that is when that question comes in about the type of test that's done. So, when we have combined tests, and this is something that happened through the years when we were going through the PHE. At first, the COVID tests came out individually. Then they started to combine that in, depending on the manufacturer where those tests are ordered. They started to combine that in. So we now had one test. It's all inclusive and it does flu A, B, and COVID together. So this is going to depend on the stock in the practice and what test they're using. If there is one swab, there is one CPT code for that combined test. That is one. That does not count as two. Now, getting back to the component about, if it's typical protocol to order all of these, but the family wants just strep because the main symptom is a sore throat, something like that. It doesn't mean you can automatically get credit across the board for all of those other tests just because usually you would give those across the board. Um, Again, I know this one is a little bit of a touchy subject here, but this is something where we have to be careful because the intent of those guidelines is not that everything's going to be a shift and automatically be fours. And we saw that a lot, especially in 2021 when the guidelines started. For me, for example, I saw pediatrics thinking, oh, everything's a four now because we have systemic symptoms with a fever most of the time. We give medications, prescription medications for acute illnesses. And remember, AMA came out and clarified that for us later on, where they said if it's more of a general symptom, meaning that it's expected to resolve itself with the typical course of treatment, then that is going to be considered a low complexity, uh, even if clinically it's a systemic symptom based on a clinical definition. So we have to be really careful what we're looking at and how we approach these different things and what it's going to mean for the outcome of the practice. Now, as far as the testing, remember, we also have to look at the type of test that's being ordered. So if there is a professional or technical split to that test, and we have both, like with radiology, this is going to be a moot point if they're ordering the test and doing it there on site because they're already getting that reimbursement of professional and technical together. So we want to keep that in mind as well. But overall, that is not going to automatically increase that complexity. One last thing I want to say on this, and I wish I didn't have to say it, but I've been asked this question by practitioners in the past. So when they find out, for example, that combination tests will count as one, if they can get credit for that as an order, I will then be asked, oh, well, should we start ordering them individually so that that can count towards a level 4? No, don't do that. The testing here should not be the main drive. And it's really frustrating to me when I hear people talk like that because it's showing, trying to play the system to some extent. And, the answer is not to change the manufacturer, to change what you're keeping in stock. You get credit for what you get credit for. Don't try to play around with that in that way. You're getting too close to the fire. Don't do it. All right. Now, the last area, these are really good questions. So I've had some people reaching out to me recently as well that either are new to the industry, to the medical coding and billing industry, or they're in that phase where they are starting to go through either looking for courses that they're going to take to get into medical coding and billing, or they're in the middle of it and want to know what the future is going to be like. One of the things that's really hard for me, and I've always felt this way over the years when I'm asked these questions, is that a lot of frustrating components of what our current industry looks like from a hiring perspective could have been avoided if people knew to do research. Now, I want to be clear, I'm not faulting people who don't do research before, because we also know that when we have different entities that are selling their coding and billing courses, whatever type of education package they offer, whether it's a technical school, an accredited college, or various programs, one of the largest sales pitches and ads we see is related to people who think that you automatically work from home and that you're going to have this great salary right away. So we even have situations where people are changing their profession because they think that these things are appealing, I should say. And then they get to this end point where some of these people are that are asking me questions and they realize, oh, wait, I can't even do that. That's such a large pay cut from where I'm at now to even get started. So for me, it's not something where I say these things and have conversations with people to discourage them from coming into the industry. I just think it needs to be a very well-informed decision. Absolutely, it can pay off in the future, but people have to understand that others that they see in the industry that are thriving and doing really well and have all of these perks put work in for the most part to get to that point. So I say all of that because the last two questions that I have here are related to each other. So, one of them, someone reached out and said, I just graduated college with my associate's degree of applied science and medical billing and coding. I'm currently studying and will be testing for my certification soon. I would like to try for any jobs available remotely as I do not have transportation to get back and forth to a job. Working from home is the only option I have. Again, this comes in, that empathetic component where you're like, man, there's so much that could have helped this person make a very good informed decision before sinking a lot of money into a program, right? So, when it comes to this, we have to remember again, it's not a guarantee that there's remote. And something that's really important for everyone to understand is that when you go into a job board, so if you're looking at Indeed, for example, for jobs, or LinkedIn is a great place as well. I know there can be some spam and things like that in there. But you'll often see jobs posted on LinkedIn. Absolutely, lots of recruiters as well on LinkedIn. So, one thing that really needs to be realized is when you're looking at jobs, especially those posted by recruiters or companies that are staffing individuals into open positions for another facility or practice or whatever it may be, those types of organizations are not there to handhold and provide education. So, what that means is that those organizations are looking to help the process and the frustrations that come along with hiring, and the people they're hiring for need individuals with experience. So that is why if you have, for example, an A, so you're an apprentice or you've completed your certification or you're close to testing for your certification, that is why that's so problematic, because they need people who already have maybe 2 to 3 years experience, and they're coming in with a list of the specialties that they need as well. So the resources are not there just from the nature of the positions to hire people with zero experience or little to no experience. So it's a misunderstanding. People are looking in the wrong place and they don't understand what that means. Now, the other question that I have here goes along with that, because somebody asked, a lot of people are talking about how nobody wants to hire somebody without experience. I want to know from experienced coders, how hard is it to work with an inexperienced coder? I thought that was a great question because I don't always hear everybody looking at it from that perspective of, why is it so awful or so hard to work with someone who doesn't have experience? And I'll tell you, that is not the problem, right? It's the resources that are the problem. So, when people are entering in and looking and struggling to find positions, you really need to be looking to work with either hospital facilities, large multi specialty outpatient practices that have a lot of opportunity in them. Working directly for the entity that is billing these claims out is where you will have the most success to start your career. So, what I mean by that is there's a lot of people in the industry that jump on risk adjustment projects, right? It's something that's easy to train. There's not as much that goes into it from that CPT perspective, and it's a lot of review and validation. So, it can be more black and white. It's not as subjective as other areas of the industry, and there tends to be a lot more positions there. Now, I'm not saying that that's a negative, but people need to understand that if you're going to go into risk adjustment, that's a different route than, fee for service and dealing with CPT, HCPCS, everything else. So there are also people who will jump into risk adjustment and then realize, oh, I'm still not qualified for the next step that they thought was going to be available for them. And sometimes things like risk adjustment projects can be temporary, right? There's different times of the year where there's more volume, different projects. Now, with the government saying that they're going to be upping their number of auditors that they're hiring for risk adjustment, I've seen a lot of people at the inexperienced level thinking like, oh, this is great. These are all of our opportunities. Again, nothing wrong with it, but let's make informed decisions. So, yes, you can go that path. Sometimes people enjoy it so much they don't even want to pursue something else. So, there's nothing wrong with trying out these different avenues and seeing what's a good fit and things like that. But don't come out of a space like that and expect that you're automatically going to come into the other side and, be qualified for recruiters and people who need experience. It's just not the reality of how the industry is, structured. Now, with that being said, the reason why it can be so great to look to your local area is that for you personally, that's going to be the best way for you to invest your time. And really, you do have to think of it as a money investment because of what I was saying about, what that salary can look like. So some people will come from being a nurse, for example, and want to get into this. Or there's a lot of dental hygienists right now that are wanting to get into coding. And they'll, again, look at that the fact that starting, you don't get to transfer your money and all of the skills don't necessarily transfer over. Now, it does help if you have that underlying knowledge, and it could help different code sets or specialties if you stick with them. But when we think about, salaries and pay and everything, chances are this is going to be a pay cut. But look at it from an investment standpoint. And if you go into it with this perspective, you absolutely can, really look to grow in this industry and have a good footing and have, really good strong foundation and resources, because when companies hire inexperienced people and they don't also invest in those people, they're not only hurting their own departments, their own companies, if they're not willing to support their staff, but it's actually hurting you, whether you know that or not, for your own future. So this is something where, jobs jobs in this industry, we don't want to look at it as a job. We want to look at this as a career. This takes an investment. It's not something you just show up to and go through the motions. This is a career. There's a lot of opportunity here, but we've got to approach it from, an informed perspective to make these decisions correctly and appropriately. All right. So, really quick before I end for the day, I saw a lot of comments coming through. I just want to look here really quickly. Okay. So Dr. Rosenstock, so lack of experience does not preclude being hired if the training process is robust. Exactly. And, that's the thing too. There are times where some of these entities go into the hiring process saying, hey, it is hard for us as well to find someone with the exact experience that we need. There's times that they're going to come into this again from that viewpoint that they're willing to invest in you, and that's an amazing match when that can happen. Okay, Tanya, yes, that is how I started and worked my way into the hospital outpatient. Yep, same with me as well. I actually started in a hospital customer service department. There's times where people will say that, you don't have to just take a job that's a foot in the door. There's nothing wrong with that either. That's actually how I was able to progress in my career and become a consultant. I was exposed to so many different areas within the hospital system. And, it just all adds up, right? There's all these things. And when I come across new situations, some of them I'm able to handle because I was a customer service rep years ago. So, it just kind of triggers memories and say, oh, well, what if we look at this? I remember this happening, things like that. LaDonna said, prior to becoming an auditor with our company, I was a team lead for the coding department. I was usually the one who would welcome a CPCA and help guide them with the world of coding and do everything I could to help them become successful. Yep, absolutely. And that mentorship is a really great perk, I would say, of being able to start with, an established organization that has those resources. All right, so we are going to go ahead and end that for today. If you are interested at all in looking at that membership, feel free to go to my website, stephanieallardconsulting.com. Like I said, I am available to assist whether you're an auditor, a coder. Some of the people that are in the membership are a part of the ownership of billing companies where they, need assistance at times, maybe leading coding departments, directors within the industry, that you need that occasional help and someone to bounce things off of. So feel free to look at that. I'd love to have you join us in that membership. There are other perks along with it. There's different educational resources that are there. There's on-demand webinars. We do private live events once a month where we do similar setup where as a group, the members in the group join and we talk through a lot of what we're currently seeing, a lot of the questions people are asking. That's always great because sometimes people have input as well if they're experiencing something similar. And then we do also do a book club. So a professional book club where once a quarter we look at some kind of book related to professional growth, personal growth, and what we can do to continue to support our own goals that we have for ourselves. All right. Well, I thank you everyone for joining and hope to see you back next week.